Good afternoon and welcome to the CAP webinar. I'd like to thank you for attending the webinar, How 2013 Reimbursement Changes Will Impact Pathologists. I'm Richard Friedberg, Chair of Pathology at Bay State Health in Massachusetts and Chair of the CAP Council on Government and Professional Affairs. Today's webinar is the first of a two-part series on how the final 2013 Medicare Physician Fee Schedule impacts pathologists. Today, Dr. Jonathan Miles, Chair of CAP's Economic Affairs Committee, and I will focus on the significant payment policy changes for pathologists in the final 2013 Medicare Physician Fee Schedule that was released in early November. Part 2 of the series will be held tomorrow, and we'll focus on the changes to CMS's Physician Quality Reporting System, more commonly known as the PQRS program. You must register separately for each webinar. So if you haven't signed up for Part 2, please visit www.cap.org/advocacy. Both Part 1 and Part 2 of the series are being recorded and will be posted on the advocacy site at the Special Resource Center on this issue, the 2013 Medicare Physician Fee Schedule Resource Center. This is located on the advocacy homepage, and I encourage everyone to visit this important resource center, which features FAQs, links to the final rule, as well as extensive stat line coverage on the final rule. As most of you know, and as detailed in the November 1st stat line special alert that you were emailed before this webinar, the most significant change for pathologists in this final rule is that CMS revalued the technical component costs of the CPT code series from 88300 through 88309, which results in payment changes to pathology services. Most notable are the changes to CPT code 88305, which as of January 1st, 2013, will see a 52% cut in the technical component, a net 33% cut in the global payment, and actually a 2% increase in the professional component payment. Additional information on the impact of high-volume pathology codes is included in the November 5th Statline article that was sent in advance of this call. The agency also announced that the newly developed molecular pathology CPT codes will be placed in the Medicare Clinical Laboratory Fee Schedule, known as the CLFS. A new CMS HCPCS code, the G code, was created for situations requiring physician interpretation and reporting of these tests for Medicare beneficiaries. Dr. Miles will explain these changes as well as CAP's advocacy related to these payment issues, both in the past and looking to the future. Unfortunately, while Dr. Mark Sinderak was slated to speak today, he is unable to join us due to a personal matter. Following Dr. Miles' presentation, we will have a question and answer session. You can ask your questions by typing them into at any time to the question box located in the GoToWebinar console. That console should be now displayed on your screen. I encourage you to submit your questions before the Q&A period begins at the end so that staff can review and select the broadest possible scope of questions. I have asked the staff to combine similar questions if possible in our limited time today so that we can cover as many topics as we can. Please note, in order to ask a question, you must also be logged as a webinar, not just calling into the audio portion. So with that as a preliminary, I'm going to turn it over to Dr. Jonathan Miles, and then I'll come back afterwards for the Q&A and wrap up. John?
Thank you, Dr. Friedberg. I'm happy that we have such a large number of attendees today. In fact, we had over 1,200 folks register for this webinar, which is the highest number we've ever had for a CAP webinar. Today, in this slide, it's an overview of the things that we're going to discuss during this presentation. First, we'll talk about Medicare's increased scrutiny of all physicians' fees, not just pathology codes. We'll go through a summary of the payment changes for pathology in 2013, what we at the CAP have done to mitigate the impact of these changes, and then go into some background as to how these changes arose and how these fees are determined. We'll then go into the next steps that we can take in pathology to further mitigate the impact of the cuts, and in closing, we'll talk about what your practice can do to prepare for these changes in 2013. Now, one of the things with this, with the surge path codes is the surge path codes were reviewed by CMS in a setting that is not particularly friendly to review any codes. And one of the things that the Healthcare Reform Law, or Accountable Care Act, did is that it did empower CMS to review and revalue high-volume codes from all specialties as potentially overvalued services. And so the 88305 code, it falls into this category of being a high-volume code. In fact, it's one of the top 10 codes from all of CPT that Medicare pays out. That's because so many different types of biopsy specimens are included in it, and the fact that a biopsy specimen is a relatively common type of specimen. The other thing with the 88305 is that the technical component had not been looked at since 1999. And in fact, the initial inputs, the resource inputs for 88305TC were at the first practice expense subcommittee. And those inputs had not been looked at since 99. And being a high volume code, it's only a matter of time that these inputs came up to get looked at again. In addition, what we're looking at on a large scale nature is that CMS has been seeking ways to redistribute resources in favor of primary care for some time. It's been well known that it's been well publicized, and there is general concern that the resources devoted to primary care are not adequate, and CMS has been seeking ways to redistribute those resources to primary care. CMS flagged both the PC and the TC of 88305 for review last year. Again, not surprising given the environment that we're in. And the other battle that we have with the 88305 is that several comments were made that, in fact, the true cost of the technical component of 88305 is $18. So in this revaluation for the TC, you know, what we're really starting at is 18 bucks and trying to fight from there. In the 2012 final fee schedule, CMS did limit review of the 88305 to the technical component only, and the PC was not reviewed again. It was previously reviewed in 2010, and we at CAP were successful in defending the value of that code. Next slide. Now, again, so the 88305 TC, it did get reviewed this past year, and what gets reviewed when you do a TC review are the inputs. It's not an actual price. So in other words, what we do at the CAP is we look at all the minutes of technician time, we submit recommendations for amount and number of reagents, we submit what equipment is used, and what the RUC does, and we'll be talking more in detail about the RUC is in a moment. But what the RUC does is it looks at those numbers and approves them, sends them on to CMS. We at CAP do not determine a price, nor do we recommend a price. What we do recommend is we recommend to the RUC is the resources that are needed to value the code. So when the practice expense initially got looked at in 1999, again, this was the first meeting of the practice expense subcommittee. Since 1999, codes get looked at a lot different now than they did initially. First of all, the committee in process has been in function now for over 10 years, so they have a more changed. The technology has changed. And also the environment that the code was looked at has changed. The committee now looks at every line and you need to describe in detail every component of an input. You know, for example, back in 1999, you could say that it took a technician, you know, X number of minutes to do a procedure. Now, when a code is reviewed, you can't do that. You actually have to say what the technician is doing every minute of those 10 or 20 minutes. We were able to mitigate the impact of this review to the TC only, as the PC was reviewed in 2010. Now, you're all aware of the bad news in regard to the TC revaluation of the 88305. I did want to alert you that some additional high-volume codes in pathology will be undergoing review this year. And any changes in these codes for immunohistochemistry, which is the 88342, or enhanced cytology, which is the 88112, those changes will take effect in 2014. So for 2014, PC and TC of immuno and enhanced cytology is being looked at. We will not be able to know the results of that revaluation until the final rule is published on or about November 1st, 2013. Now, what we at CAP do throughout this year, we're going to be continuing to advocate through the RUC process to mitigate any potential adverse effects on the profession. Now, the other high-volume service that's been in the news a lot is in regard to the Palmetto prostate biopsy policy. And Palmetto is the Medicare contractor for the J1 jurisdiction, which includes California. The Palmetto had a policy that applied the G codes to all biopsy specimens. The Federal Register stated that the G codes for prostate biopsies only applied to saturation biopsy specimen, which requires that a person doing the biopsy use a specific procedure code. We objected to the Palmetto policy, and we have had a meeting with CMS about the Palmetto prostate biopsy issue. We did urge CMS to rescind the Palmetto policy, and in the final rule, which was published, there was no mention of changing the application of the G codes from saturation biopsy to anything else. Next slide. So the 88305, it was selected for revaluation this past year. And when the RUC revalues a code, typically what's done is you don't revalue one code, but you evaluate all codes in the family. So 88305 is part of the SurgePath family. So in fact, what got reviewed by the RUC was the 88300 through 88309. And the reason that you increase in the PC for 88304 and 88305, and an increase in the TC, PC, and global for 88307 and 88309. And you may wonder, how can you get an increase in the PC if the code did not undergo additional review. The reason is indirect costs for a particular test are allocated to both the TC and the PC. So, in fact, if you do get a decrease in the TC, the indirect costs are allocated over a different metric, and because of that reallocation of the indirect cost, we did get a slight increase in the PC for 88305. Now, another question that folks have had is that, we've mentioned that the TC actually hasn't been valued since 1999. But we've got several questions that have said, well, the dollar increase in the TC has in fact gone up since 1999. That's true. And what happens is that the inputs actually don't change, but what has changed is the value of the inputs. So for example, the cost of a liter of alcohol has gone up. So CMS takes that into account in deciding what the cost will be or what the payment will be for the technical component. As I said, the change in TC for 88305 actually impact all pathology codes, and that's because this decrease in the TC affects the allocation of the indirect costs. And you did receive a handout earlier today by email. It's the second stat line article from November 5th, which at the end of that article there's a very nice chart which shows the impact of the new values on a variety of pathology codes. Many codes actually saw a slight increase in their value. The overall impact for pathology is a loss of about 6%, and that number is calculated on the basis of an average practice doing an average number of specimens in all the various pathology codes. Now, nobody is average. If you do a lot of TC work, okay, or any TC work, you're going to receive some impact from these changes in valuation. Okay, next slide. Now, other changes for 2013 that will be impacting pathology. There is a 7% increase for family practitioners. This increase of 7% is spread across all specialists. So to get the increase in payment for family physician, basically it's going to come from all specialists. And that resulted in some of our decrease on the PC side as well. We also were cut an additional 1% from practice expense methodology change phase-in. This is basically a change in the Medicare formula, which we really can't do anything about. And finally, for 2013, unless Congress does something, there will be a cut of 26.5% based on the SGR cut. Now, Congress is expected to avert this cut. Over the past 10 years, it's been able to avert this cut every time. We're not going to know, though, till they actually do it, what will happen. The other potential effect here for 2013 in pathology is the fiscal cliff. If Congress does nothing, what will happen if the sequestration budget cuts take effect, there will be in fact another 2% cut to Medicare. Okay, and the last part of the good news here for 2013 is that the technical component grandfather termination was finalized, and inpatient services are paid as part of the DRG, and outpatient hospital services are paid on the APC scale. Okay, next slide. In the 2012 final rule, the molecular pathology CPT code placement was disappointing news for us in pathology in that these codes were placed on the clinical laboratory fee schedule rather than the physician fee schedule. The clinical laboratory fee schedule is referred to as the CLFS. The physician fee schedule is referred to as the PFS. CAP advocated for several years to get these codes on the PFS. Although the codes were placed on the CLFS, CMS did allow a G code for recognition of physician work, and we'll be talking more about that in the next couple of bullet points. What's news about the CLFS placement of the MOPATH codes is that they will be gap-filled for 2013. And I'd like to take a moment to talk about what a gap-fill payment is. Traditionally, codes that are placed on the CLFS are crosswalked to existing codes which have a set payment amount. If insufficient data exists, the codes are not directly crosswalked, but what happens is that the codes get filled by what's called a gap fill process. And what happens in the gap fill is that each Medicare contractor will separately determine its price for a given test. That's what will happen in 2013 for the molecular codes. In the second year, what happens is that CMS typically will set a national price, taking the average of the pricing for all the Medicare jurisdictions. Each carrier will determine its own price, and it determines its price in a variety of ways by getting information through whatever means possible. And in fact, at CAP, when we were advocating for placement of these codes on the PFS, what we did is we actually did practice expense determinations for these codes. We went ahead, submitted them to the RUC. The RUC did review these and forwarded a recommendation to CMS. And CMS has published the RUC recommendations. So there is some hard data out there that CAP has provided and advocated for. Now, although the codes are on the clinical lab fee schedule, there still is room for a pathologist in the process, in the pathologist interpretation for these molecular codes. And since the 83912 code is being deleted, CMS created this G code for pathologists use to bill for their interpretation if medically necessary. There are various requirements that are necessary that need to be fulfilled before the pathologist can bill the G code. CMS throughout 2013 will be monitoring the utilization of this G code to determine if it is necessary. The thing about the new molecular codes is that these new codes are replacing the existing stacking codes, which has been the traditional way to bill for molecular pathology services. The CAP, since from the onset, has opposed CLFS placement, and we support the recognition of the pathologist's work. These molecular tests we feel are different than other tests in the clinical laboratory. When a glucose comes off a machine, it can go to the floor, and the internist can interpret it. With the molecular tests, what you get is dots, blots, and graphs, and a professional needs to convert those dots, blots, and graphs to a clinical meaningful result. You can't send the dots and blots to the floor. Okay, next slide, please. So now in the next few minutes, we're going to talk about the code valuation process. And certainly the 88305 TC revaluation has prompted a lot of questions in this regard. What happens when a code gets reviewed is CMS submits a request for code review to the AMA Specialty Society RVS Update Committee. That's known as the RUC, Relative Value Update Committee. And this is a group of about 30 people, physicians mostly, and in order for a code to get revalued, 2/3 of that group has to agree with the value for a code. So it's not a slam dunk to get everything through the RUC. And, you know, with healthcare dollars, it's, you know, basically an apple pie. So if you take a little bit, if somebody gets a little bit bigger piece of pie, okay, somebody's going to get a little less. That's just the way the system works. So everything really does get looked at, and the RUC, again, does not determine a dollar amount, but what it does is it evaluates each code in relation to other codes, both within the specialty and outside the specialty. And we are fortunate in pathology to have one of the permanent seats on this committee. And our RUC member and our RUC alternate member actually sit at the table and can vote and can question other specialty societies. We also have a pathology advisor at the RUC, and actually that is my job. And what my job is to present and advocate for the society to those other physicians in order to obtain a 2/3 majority vote. The RUC recommendations are made with input from specialty societies. And typically what happens is that the specialty society presents recommendations. Those recommendations do get deliberated in detail, line by line, and either the RUC will support those recommendations or the RUC and the specialty society will have some dialogue and come up with a new recommendation. It is also possible for the RUC to submit a recommendation that the specialty society does not concur with. CAP sits on the RUC advisory committee to advocate before the RUC. And what we do is when we present data for when we present a recommendation for a code, we collect the data. We collect data from you, our members, as well as laboratories to present recommendations for both the practice expense as well as the professional value. The RUC then submits these recommendations to CMS. CMS may or may not follow the RUC recommendations. And then the final decision of a code value is based in the final fee schedule rule of each year. So just because the RUC recommends something doesn't mean CMS is going to accept it. They often do. They often tweak it a little bit, but really nobody knows until November 1st what the final determination of a value is. Okay, next slide. Okay, the RUC oversees the survey process of the codes. And what do we mean by survey process? Okay, the professional component and the technical component are valued by completely different processes. One does not have anything to do with the other except for that minor allocation of indirect costs, which we talked about. So in other words, let's say that your TC, for whatever reason, goes up 50%. Okay, if your TC goes up, that does not mean that your PC is going to go down. If your TC drops, it doesn't mean the PC goes up. Each component of a code is valued completely independently. In valuing the physician interpretation component, the PC, one of the things that's used in formulating a recommendation is the survey. And when a code gets valued, a survey will go out and it will ask members to compare the code in question to various codes using a variety of parameters. The information from that survey is used to formulate, in part, a recommendation to the RUC, and the RUC actually does see the results of that survey. So you look at that survey results for the code, compare it to other codes, for example, in pathology that are already RUC valued, and you just compare the codes to some of the other codes in clinical medicine that have a similar amount of time. And a judgment is made as what a fair RVU is. The practice expense is determined by a different process. There is no survey process which is typically used for practice expense. What you do is you look at a typical case, determine all the components, all the work involved in that case, submit them to the RUC. The RUC will typically refine those inputs, send them on to CMS, and then CMS will refine those. Now, what the RUC sends on to the CMS for practice expense is the direct cost or direct inputs. Indirect costs are not included in the recommendations. So it's possible for the RUC to actually approve an input on practice expense, but CMS could say, well, yeah, you do use that, but it's not a direct practice expense. It's part of the indirect practice expense or overhead. So we do submit these recommendations to the RUC for both physician work, practice expense, and also professional liability insurance crosswalks. We present our recommendations to the RUC, and the RUC meeting occurs 3 times per year. CMS, or rather RUC, sends all its recommendations to CMS, which are confidential until CMS publishes them on or about November 1st of each year. Okay. So what types of data does the CAP collect for the RUC? Professional side, the relative value unit recommendations are collected through the survey process. The physician work RVUs comprise the majority of the professional component. It also includes some indirect costs. In the survey, we ask you to compare the time, complexity, and work of the surveyed services to an existing service. So, for example, now we have a professional value for the 88305 that's been through the RUC. If we have a new procedure that comes out, one of the codes on that reference service list will be 88305. The question to the survey respondent will be, how does this code compare to 88305 in terms of work? And those reference services basically are RUC-valued services. Okay, next slide. The practice expense recommendations, these are inputs of clinical labor in terms of technician time, medical supplies, medical equipment, and time for each medical equipment is used for each case. The practice expense RVUs do comprise the majority of the TC. An important point is that the CAP does not provide pricing recommendations for the TC. What the RUC does is it looks at the components that are necessary to produce the TC for that code in terms of technician time, amounts of reagents. We make recommendations for each code. We actually have to collect invoices in the field which are redacted to justify the actual cost. That does get submitted to the RUC, and the RUC approves or modifies and sends that list to CMS. CMS is the folks who actually converts those inputs into a price. And our job at the CAP is to make sure that those inputs that are used are correct and representative. And in fact, when we do submit recommendations for the TC, we have a rather large group of people look at them, small practices, large practice, academic centers, non-academic centers. We also have some folks in the large reference labs also involved in the process as well. The practice expense recommendations undergo review prior to CMS submission. Once those direct inputs are determined, CMS has a practice expense formula to determine what the actual practice expense RVU is. That RVU is multiplied by the conversion factor to arrive at a dollar amount. Okay. Now, for 88300 and through 88309, we went through this process. And it was a painstaking process. I want to thank everybody on this call who participated in providing us data. Now, even though we determined that some things were an expense, and in fact the RUC approved some of our direct inputs that should be used to calculate payment, there were some things that CMS did not accept from the RUC recommended values. In calculating practice expense for the surgical pathology codes, we included various things in the list in front of you that were not considered to be direct costs by CMS. Specimen, solvent, and formalin disposal cost or hazardous waste costs, courier transportation costs in gathering the specimens from doctors' offices, laboratory information systems, COPAS software, as well as maintenance contracts. It was our position that these were all legitimate costs that could be attributed to a specific patient. CMS did not, in their initial determination, feel that these were direct costs. However, in the final rule, they do state that they would like more comment on these issues. And we will, CAP will be doing that. The other thing is for 2013, these TC values for 88300 through 88309, these values are interim values. So in the final rule, CMS put a caveat in there that what they want to do in 2013 is get some independent verification of the number of blocks used to create the direct inputs. And in fact, in the final rule, they do state, well, the assumptions that were made for each code, the block number. So we determine the inputs based on the typical number of blocks used for the code for the vignette used, which was selected to be typical for that code. That vignette was previously approved by the RUC research subcommittee. So that is something that we will be doing over the next year to get some additional evidence to validate the number of blocks used in our assumption. Also, the RUC will be doing the same thing. So what does this mean to you as a pathologist? It means that these values for 2013 are interim, and that we at CAP will be working as hard as we can to gather objective data so that we have some objective data to verify the typical number of blocks for a given code. Okay, next slide. So that is a situation that we are faced with for next year. Certainly, this is a difficult situation for pathology. It was not avoidable. This has been in the works for several years. We have successfully mitigated against any significant reevaluation of the 88305. The 88305 TC had not been evaluated since the initial practice expense subcommittee. It's a high volume code. They're looking for money to shift to other parts of Medicare, such as primary care. And third thing is the committee looks at stuff line by line. CMS looks at stuff line by line. So the numbers that get submitted are strived to be as accurate as possible. We also had the headwind is that we started at $18 TC for the 88305. There were numerous individuals who have publicly commented that that should be, in fact, the correct value for the TC. So what are we going to be doing soon? We're going to be working with all stakeholders and the RUC to address the following issues. We have a list of RUC-approved items that was removed by CMS in its final calculations for the 88305 TC. Some of those costs were, in fact, quite significant, such as courier transportation costs. What we're going to do is advocate that those costs are, in fact, direct costs and may be attributable to the specific benefit of a specific patient. We're going to clarify and validate the number of blocks used for each service to prevent further cuts in the value of these codes. We're going to continue to push for recognition of pathologists' work in molecular pathology and strive to make the G code permanent. If you have additional questions on what steps we are taking, you can contact Todd Klemp. He's in the Division of CAP Advocacy out of the Washington office. His email address is listed there at the bottom of the slide. Also, please feel free to contact me directly about further questions you may have. My advice for you is to be prepared for these changes in the coming year. Given that we know what the value is for the TC and PC of the various surgical pathology codes in 2013, assess the potential impact on your practice. The impact on your practice is going to depend upon the various code distribution in your practice and the nature of your contracts and billing arrangements. You're going to want to look at the percentage of your TC billings, the distributions, and how changes in Medicare reimbursement may affect other billing arrangements or contracts you have. The bottom line is that if you bill the TC, any change will affect your practice. Next slide. Okay, now we're going to now have a question and answer session, but before we get to that, I'm going to turn the program back over to Richard.
Thank you, Jonathan, for the comprehensive presentation on how our codes are valued, the downward pressures confronting physician payment, and what CAP's role is to best influence this process. Before we start with our questions, I'd like to address some 5 frequently asked questions on how CMS's process for recommending values for physician services and some related issues. These are some common questions we've got, and there are 5 that I just want to run through before we get into the additional questions you're going to ask. So the first question we commonly get is, why don't we just take dollars out of the TC and put it into the PC? And there really is only and the answer is that there's really only a small relation between the TC payment and the PC payment for any service code, and there really is no trade-off from one component to the other. Each component is valued independently with entirely different inputs for each one. The allocation of indirect costs, which are split between the TC and PC and include costs such as overhead, can shift with the reevaluation of either the physician work or the practice expense RVUs, as they are all part of Medicare's indirect cost formula. This is how we end up with a 2% increase in the PC of 88305 based on the TC reevaluation. Another common question is, well, where do the salaries for histotechs and transcription fit in? Well, the time histotechs spend preparing the specimen are part of the direct medical inputs, which also includes other medical labor, medical supplies, and medical equipment, which are all used to value the TC, the technical component. Costs for transcriptionists are considered part of overhead or indirect costs and are spread across both the TC and the PC, with the direct costs driving where those costs go. A third common question is, what about the cost for rent, equipment, xylene, couriers, computer systems, and so on? Well, rent is considered part of overhead, which CMS considers an indirect cost and spread across all the codes as I just described. Equipment and xylene are considered our direct medical equipment and supply costs and are part of the technical component. Now, computer systems, that's an issue we are still debating with CMS, as we believe it is a direct cost. The fourth common question is, isn't it simply that the PC is what I get for looking at the slide and the TC covers everything else? Well, the PC does include the physician time, mental effort, and medical judgment. However, indirect costs considered overhead are also part of the PC, and how much of that goes into the PC is part of CMS's formula that takes into account pathology cost per hour allocated to the codes using its part in drivers, using in part as drivers the direct costs. That's why we are seeing slight changes again of the PC pathology codes based on the reevaluation of the TC costs. And the last common question that pops up is, if I'm employed by a hospital system and only see specimens from inpatients, how does this affect me? Or if I'm employed by a standalone lab and only see specimens from outside groups, how does this affect me? Well, the reevaluation of the technical component has a slight impact on the professional component, however. For inpatients, however, the costs of the technical component are included in the hospital's DRG payment. For a standalone lab, if they are billing global services, then the reimbursement is changed as the change in TC affects the overall global payment as illustrated in the chart included in your handout. So those are some common questions. We should have a handful of questions that have been coming in. Now we're going to move on to the Q&A portion of our session. So as described earlier, please send us your questions electronically to the questions dialog box located at the bottom of your console. As a reminder, you must be logged into the webinar console to ask a question. So Julie, can you begin with the first question, please?
Sure. First question is, will Medicare consider making adjustments to the 88305 TC for 2014?
Yeah, the answer to that is yes. The values that were approved for 2013 are interim values, and CMS will be looking at a variety of things in determining what the final price will be for 2014. They have solicited comments on block numbers for the various codes. They've solicited input as to how they can attribute, how we in pathology can attribute computer systems, CoPath software to an individual patient. And they also state in the final rule for 2013, they state what they didn't include from the REC recommendation. So we have the opportunity here to make comment on what they decided was indirect and make the argument that it was direct. So we do have the potential for the code to go up for 2014, stay the same, or go down. We don't know what's going to happen, but what I can tell you is that we at the CAP will do everything in our power to represent the costs as best we can.
And before we go forward, Dr. Miles, can you just again repeat what RUC stands for? We've had a few questions to clarify what that means.
Yeah, RUC is Relative Value Update Committee. This is an AMA committee, and the job of this committee is to recommend to CMS RVU recommendations for the professional component of all physician services, and also to determine practice expense recommendations for the technical component for all physician services. Now the RUC submits those recommendations to CMS. CMS turns them into a dollar amount. They may not accept all the RUC recommendations. They may make some modifications. Common thing is what happened with the 88305 TC, is that the RUC made recommendations. The CMS is not disputing that they are a cost. What they are stating is that those inputs are in fact indirect specimens rather than direct specimens. So that is really what the RUC committee does. Now, it's a very important committee, but a lot of folks in the medical community aren't real familiar with it, and they're not familiar for a variety of reasons. One is that the RUC recommendations are, you can't talk about them publicly till after the final rule is published, because the RUC can make a recommendation, but CMS, may not accept that.
Dr. Miles, can you, there was also a question about pathologists representation on the RUC. Can you just give a brief explanation on that?
Yeah, the RUC has actually about 30 seats on it now, and all the major specialties and primary care and general internal medicine are on the RUC. Now, there obviously is more specialties than there are seats, so there are some rotating seats that would include some of the smaller specialties that they rotate in and out. And the RUC members, the way to think about it, think of them as a judge. What they do is they listen to a specialty society's presentation. They vote it up or down. If they vote it down, the specialty society goes what's called a facilitation committee. Sort of think of it as a conference committee where a recommendation is come up with to go back to the full RUC. To get anything passed by the RUC, you need 2/3 vote. So you've got the RUC members, and we do have a RUC member, Dr. Alan Tucker. We also have an alternate, Dr. Meg Neal. They serve us proudly at the RUC, voting on all codes that come before the RUC. They question all specialties on their presentations. We also have a pathology advisor. Anybody who has a code that gets presented to the RUC has an advisor, and it's the job of the advisor to advocate for the code. In other words, I make the presentation and present the information and our recommendations. our RUC members, the pathology RUC members, they cannot comment on the pathology codes. The only person that can advocate for pathology is the pathology advisor. Now, the other thing, before we leave the RUC question, we have codes that we are not the only specialty that performs the service. So when you have a code that's performed by multiple specialties, typically you'll have a lead specialty who will make the presentation, but it will be in consultation with the other specialties to formulate a recommendation. And it's in everybody's interest who uses the code to come up with a recommendation that everybody can live with prior to the presentation.
Dr. Miles, we've had a number of questions about the specific expenses in the technical component. One is, were courier and storage expenses left off of the technical component? And if so, how should we recoup these costs?
No, we actually included all those specimens, all those inputs into our recommendations. And in particularly in regard to the courier transportation cost, that was actually not included in the 1999 evaluation. One of the things that we came up with is to add that. And in fact, we gathered data from actual hard data from several sites, and that cost was significant per specimen, much higher than we anticipated. So we did submit that. The RUC accepted that, but again, these were not. It was not accepted by CMS. It was attributed to be an indirect cost rather than direct cost. But now what we're going to be doing is going back to CMS and advocate that, in fact, it is a direct cost. The other thing is that, storage costs, chemical disposal, the formalin disposal, excess tissue disposal, all that was looked at. Some of that was not included in the original evaluation in 1999. We added that. We tried to get anything that was a cost, we tried to include, and with that, CMS also determined that that was an indirect cost. I can tell you that we also tried to get a specimen requisition cost, and that was actually, that didn't make it through the RUC. That came out to a penny a case. So we did everything we possibly could, submitted every possible cost that was in there, and some of the stuff is just determined to be indirect, and we're going to be coming back and trying to advocate why it is attributable to a specific patient and why we think it should in fact be part of the TC calculation as a direct input.
We've also had a few questions about the comments that CMS received about the claiming the $18 cost of TC.
Yeah.
From one of the studies that was used to substantiate this, it's quoted as $18 per slide, but if you look at it from a specimen perspective, doesn't this go up? Are you quoting $18 per slide or per specimen?
Well, I think that the questioner has read that particular article in great detail. And in fact, in that particular study, which is being alluded to, it's $18 per slide. However, there are other sources out there that claim it's $18 per unit of 88305. So the other thing is that you have to realize the practice expense determination by the RUC has a certain set of rules. It's actually not quite the same technique that you use if you own a business and determine what your cost is. The way the inputs are determined is by what I just described. What you determine is, amount of xylene per case, amount of technician time per case, amount of equipment time allocated to that specific block. You include all that material, and that's what gets approved. CMS has a complex series of formulas that they apply to those direct inputs to get at the dollar amount.
Do the TC cuts to the 88305 impact the APC rates?
The answer to that is no. And there may be folks on the call who are not familiar with the APC rate. Basically, in pathology, we get specimens from a variety of sites and types. And depending upon where that specimen comes from determines how we get paid. For example, let's just take a mastectomy specimen, okay? If you're in a hospital lab, okay, that patient typically is an inpatient and is going to have a mastectomy. It's going to come to your lab. So, your CPT code for that mastectomy specimen, let's say, is an 88309, but in fact, you're paid through the DRG. And that is why some of these increases that we saw for the 88307 and 88309, they look pretty good. The problem for pathology is, of course, that most of these are covered through the DRG, so they'll have a very minimal impact on the pathologist's revenue. The other way we can get specimens is through a hospital outpatient means. And these types of cases are the ones that are paid on the APC schedule. And the remaining cases, typically from doctors' offices, are what are paid on the physician fee schedule. And that is what we're talking about here, the value from the 88305. So you're going to have to know your case mix really to determine what your value is. Now, how is the APC determined? Okay, the APC is not determined in the same way as the valuation on the physician fee schedule. The APC rate is determined by hospitals submitting data to CMS on their actual costs, and CMS comes up with a price that it will pay. And in fact, the revaluation of the 88305 TC, that revaluation actually is very close to the APC payment currently for an 88305. But in answer to the question, the APC payment should not be affected by this 88305 TC revaluation on the PFS.
And is there any way to avert the 88 series cuts for 2013?
No. I think that the final rule is the final rule.
We have some questions about SGR and fee-for-service payments for Dr. Friedberg. Dr. Friedberg, can you speak about the likelihood of, or speak about Congress interceding to prevent the 27% SGR cut?
Yeah, I'll address that one. The SGR, just to make sure everybody's on the same page, is the sustainable growth rate, and it's the when the BBA of 97 came through, the cost of physician adjustments for payment was supposed to go at the rate of inflation. But what was different was it went by the rate of inflation instead of the rate of medical inflation. And medical inflation has been a few points higher every year. And every year since for the last dozen years or so, Congress has made passed a bill, usually at the last minute, to not implement the SGR that year, and it simply pushed the kick the can down the street a little bit. So right now we are at a cumulative 26.5% difference between what we're getting paid now and what we should have been paid under the original agreement. So when this last came up, which was earlier this year, they got in place an agreement that to last to the end of 2012. And if nothing else happens on 1/1/13, that SGR fix automatically goes into effect, and it'll result in a reduction in Medicare payments of 26.5%. The problem the government has is that in order to fix this, it is something like a $300 billion problem over a 10-year period. And given the state of the political environment right now, those dollars would have to come from somewhere else. And there were all sorts of comments about, oh, can't we take the money from getting out of the Middle East sooner, or so that sort, try to redirect the monies over towards us. But the Congress but this is such a large percentage cut. This Congress is going to have to do something. And if you look at what they have proposed in the past, as recently as a year or two ago, there was a proposal where all the specialists would take a 5.9% cut for each of 3 years in a row, cumulative somewhere around 18 to 20% cut, and then it would be a flat figure for 7 years thereafter. That did not pass, but when that came up, where they were talking about an SGR problem of probably somewhere around 20, 22, 23%. So now the problem is closer to 27%, and I think everybody expects that something will happen. It's a bit of a game to try to figure out exactly what that's going to be. So everybody I know talks about that says that there will be some sort of deal made. You covered it the last minute. However, jury is for quite a while on that one.
Dr. Freeberg, we're having a little trouble hearing that last answer. Maybe you want to check your connection.
Okay, I'll try this.
Yeah, I think that, basically what that Dr. Friedberg's saying is, every year for the past dozen years, Congress has fixed this cut at the last minute. And, it's anticipated that they will fix it again this year, but there's no guarantee. So, in particular, I think we're a little bit vulnerable this year because of all the other issues that, the Congress is dealing with. The thing about the SGR is you have to remember that it's not a pathology-specific issue. So basically, we have the entire House of Medicine on our side in this issue, and the AMA is taking the lead in fighting this cut, and certainly we're supporting the AMA and assisting them in this effort.
Dr. Freeberg, can you speak a little bit about CAP's position on finding alternatives to SGR and fee-for-service?
Well, I hope you can hear me now. The AMA has put forth a proposal for how to fix the SGR, and the CAP is supporting that proposal. And at a very high level, what that proposal says is to skip the SGR for right now. Over the next 5 years, give us payment increases corresponding to what the professional side should be seeing based on professional insurance, professional rate of inflation, and over the next 5 years, figure out a new system to have physicians choose from. So the AMA is putting forth a proposal, and the CFP is supporting that proposal. But again, there's going to be a lot of proposals, and we're going to have to see exactly how this all plays out with Congress. Just remember, this, as Dr. Miles pointed out, this does affect all physicians, and so we're all in the same boat on this one, but it is a very, very significant cut. And we're also at a time when there's no election for 2 years, so it's not, we don't have the benefit of an election coming up fairly soon that people are going to be very concerned about their votes on.
Yeah, Richard, I certainly agree with all that, and the thing is about the AMA proposal, which I really think is very significant and that we need to advocate for, is that in any of these payment reforms that are going on, we want to make sure that we reward physicians for any savings achieved across the health care spectrum. In other words, we want to be rewarded for some of our work that we're doing to help the system.
Can you, both Dr. Freeberg and Dr. Miles, can you give us your thoughts on the realistic expectations for Medicare to remove anatomic pathology from the Stark in-office ancillary service exception and make client billing illegal or enforce billing arrangements as undue incentive or kickback to send Medicare samples to a particular laboratory?
All right, I'll address this one. This one has been a very hot button issue for many pathologists for a number of years. And whenever this comes up, we've had plenty of discussions with CMS and MedPAC and a few of the other groups about how to approach this. And invariably, we run into a problem, and that is much of the House of Medicine is against us on this one. And recently, the General County Office had a presentation or a publication on self-referral for imaging, and it was fairly blunt assessment that when people get their own imaging devices, they certainly use them a lot more. That came out in the last couple of weeks, and we're expecting a follow-up on that in pathology, which may help us with our argument about the role of self-referral in utilization. We've repeatedly gone to CMS and to Congress with this one, and it's just difficult to get across to people because it's a relatively small item in the bigger picture. Remember, there aren't that many of us, and a lot of the physicians are against us on this one. So we're going to keep on going at it, trying to with MedPAC, with CMS, and with Congress, trying to figure out a way to do this. It's just very difficult to figure out how they're going to implement it. And part of the problem you run into is that large groups, of 1,000 physicians or academic centers or Cleveland Clinic or Mayo or any of the other large groups can refer to themselves for legitimate practice reasons. And how small do you have to make the group before you say it's not a legitimate self-referral arrangement? So that's part of the problem we're facing here is how to define the groups that this applies to, and we've gone down a path with also trying to look at whether it could be based on the timing, and that is if you go back to the idea of a physician office lab where it made perfect sense for a primary care doc to run a pregnancy test or CBC or a urinalysis in his office because it made a difference in that patient's visit. But many of the anatomic studies that we're talking about do not affect that patient's visit and are only being clearly are being done in the office for business reasons instead of completely independent reasons based on quality in many cases. And so we've tried to go down a path trying to look at to see whether there's a time connection that's been made on this one, and the appetite on the part of Congress and MedPAC and CMS on this has just not been there. So we're going to continue to raise the issue there. The problem is always in defining it. We cannot limit 88305 to only us and not the people, many of us who may be employed by other groups. That part of it doesn't work. So this is going to be a continual challenge. It's a known frustration. I think what you'll find, however, is that the 88305 technical component revaluation we've just been talking about changes many business plans for groups that are heavily dependent upon outreach specimens. And a lot of those are pathologists, and some of those are non-pathologists in those sort of environments, but it is a significant enough cut that it will affect the business plans. And I've had a number of pathologists come to me and tell me that the problem with the PCTC split was the root of all evil with regard to the in-office ancillary services exception. So we're going to keep going at it, but it's been a very difficult road to hoe.
Yeah, I think that our members have a lot of interest in self-referral, and the self-referral issue, it's not confined to pathology. There are other specialties that are affected by this as well. And I think there's two components to the self-referral problem. One is you have an awareness issue, and I think that we have been successful in educating folks that need to know about what the issues are in self-referral and pathology. The other component to the self-referral issue is a solution, and there's various ways to solve that to solve a problem, we want to make sure that we solve a problem that doesn't cause other problems and, in fact, infringe upon legitimate business practices. So finding the solution that actually gets rid of the problem that we want to get rid of is problematic. And, you know, the government, if they do fix it, they're going to want to fix it in a way that solves the problem and not create additional problems. You know, we also have a changing healthcare environment. You know, we have an increasing number of ACOs, and, you know, this may have an effect on the self-referral issue. There's a variety of things in play here, which is why this issue is extremely complex.
There's one other point I'd like to support John on with this, and that is most of Congress, when we've spoken to them, and CMS as well, about the problem we have with self-referral of anatomic pathology specimens, will tell us that this is a symptom of the failure of the fee-for-service problem, and we need to change the fee-for-service problem. And so if any effort we're putting into this issue, they see as a temporary effort, until we get the final resolution of whatever flavor of coordinated care or convolutional care, whatever sort of payment system we have to put in the future. So this is largely seen as a historical accident and a problem based on that part of it, and the solution is a different payment system, which may or may not be in our interest.
Great question.
We have some questions about the blocks. What was the number of blocks per CPT code 88305 and 88304 submitted by CAP versus CMS's assumptions?
Well, CMS did not assume anything. We recommended to the RUC various components and various block numbers, and CMS did publish in the final rule what we submitted, and they did you know, request some independent verification of that. And when you come up with a vignette for a code, 88304, 88305, or any code that goes to the RUC, what you do is you come up what's called a typical vignette. And it's thought to represent the typical practice or a typical case that would be associated with that code. And for the search path codes in the RUC database, we know what ICD-9 codes are associated with what CPT codes. I mean, it's published right there and collated. So what we do is we look at those ICD-9 codes, and basically what we do is we use those ICD-9 codes and come up with a vignette which would be representative of the service. And for example, with the 88305, clearly the skin specimens are the most common specimen, and the vignette reflected that. And for the 88304, I believe the lipoma type vignette was selected. So we based our calculations on the 88304 on the basis of 2 blocks, and for a typical skin ellipse, we said that 2 blocks would be typical. Now, there are folks out there that will say, well, for a prostate TURP, you know, you have 15 blocks. You know, and that's true, okay? There are also specimens where you have 1 block. So when you do your typical assumption, you come up with a case that sort of represents the code as a whole, and our vignettes reflected what was in the ICD-9 determination.
We have another, Dr. Mills, we have another question about the RUC. Can the RUC consider the cost differential between a physician office lab and an independent lab, since office labs generally do not have certain costs such as transportation?
What you do is typical. The key word at the RUC is typical, and the codes are valued based on the typical case, so you don't have different prices for different locations. For the codes that are on the physician fee schedule, a non-facility input is what is typically the typical vignette. So it would not be as for a hospital inpatient. The cost would be determined typically what would happen in an independent lab, because that would be your code on the physician fee schedule.
We have a few other questions about codes. Just give me a second. Where can we find CAP's PE input and the RUC's recommendations to CMS for 88305 and the molecular pathology codes?
Okay, I believe they're in the final rule. CMS did publish those recommended inputs in the final rule for the surgical path codes. I believe in the proposed rule they published the RUC recommended PE values for the molecular codes. So they are in the proposed rule for the molecular and in the final rule for the surgical path codes.
Okay, and is a question about TC versus PC. Is grossing a specimen part of the TC or the PC?
The PC is the physician work. So when you do physician work, when the codes get sent out for survey, each code is surveyed individual. For example, the 88300 through the 88309. Each of those codes receive a specific survey. So when the physicians fill out the survey, what they're asked is, how many minutes does it take to do this typical case, okay, taking into account, grossing, microscopic, dictation, this and that. We spell out in the questionnaire, what's included in those minutes. And then the person who fills out the survey also compares that code, all the physician work, to other codes, okay? So when we do a survey, we do not specifically separate out which portion is, how much of that is allocated to grossing or not.
Looking ahead to 2014, what are the codes to be targeted by CMS in immunohistochemistry and enhanced cytology?
Yeah, the 88342
okay.
and the 88112. Those are the two codes that will be looked at this year for new values, potentially new values in 2014. And again, not surprising that these codes are being revalued. There's been a lot, as you know, in the medical news about the 88342, and in fact that code has never undergone RUC review. It was initially valued in the early 2000s on the basis of a CMS crosswalk, so it's actually never been RUC surveyed and never gone through a rigorous practice expense process. The 88112 code, in fact, went through the RUC a little over 5 years ago when that code was new. So that code actually has been valued by the RUC before, but it is a high volume code and it has not been valued since its inception. So So again, not surprising that this code has been selected for review by the agency.
We've had a few questions about private insurers. Given the reevaluation of 88305, how do you think the private insurers will react, if at all?
Well, you know, the thing is, in my business, I don't like to speculate. So, you know, the only thing I can say is that, you know, some insurers do take Medicare payment. You know, they tie their payment to Medicare rates, but, you know, that's going to depend on the individual insurer and the individual contractor. So each case will be individual. However, I think it's safe to say that the decrease in valuation for the 88305 TC will not be good for insurance payment of the technical component.
And here's a question. If you consider a practice with no TC component billing, only PC, does the fee schedule actually go up for 2013? And what is your prediction for the PC-only pathology groups beyond 2013?
Well, the answer to that is, yeah, the PC did go up a couple percent. So potentially you could actually, if you're a PC-only biller, conceivably you could have a couple percent increase, but there's a couple buts in there, and there's some assumptions. One is you're assuming the SGR gets fixed completely for this year. You know, that would be the biggest thing. You know, for 2014, you know, I can't tell you. We have changes in Washington occurring. We have a move towards an accountable care organization environment. We have a movement that is pushing resources away from specialists into primary care. And under the Accountable Care Act, the Secretary can choose to review the codes as often as they want. So, you know, yes, we do have a headwind. However, we at the CAP and in pathology are going to advocate to keep as much money as possible in pathology and to present the data in such a way that that can be done. We want to make sure that we advocate for what we actually do and make sure we capture every possible thing we do and make in our case. And in fact, with the 88305 TC, that's what we did. We tried to get courier transportation. We tried to get hazardous waste disposal. We even included a xylene recycler in our expenses. So, you know, we're doing everything we can. That is our job in this tough environment. We have to do it. And, you know, it's going to be a tough environment, but we're going to do the best we can.
And just one last question. Are these rate changes to 88305 completely independent of the doc fix? And will they take effect regardless of whether Congress acts?
Yes, the RVU changes are independent of the fix. The fix is a completely separate process. So it's safe to say that your TC is going down. No question, for 88305.
The doc fix is usually referring to the SGR problem.
Yeah, that's what I assumed the questioner was referring to, and thank you for clarifying my answer, Richard.
All right, well, it looks like it's time to sign off. I'd like to thank all the attendees for joining us this afternoon. As I mentioned earlier, this webinar was recorded and will be available for download from the www.cap.org/advocacy website. Also, just a reminder, the advocacy website features the 2013 Medicare Physician Fee Schedule Resource Center, which has links to the final rule, FAQs on the rule, and stat line coverage. Replays of this and part 2 of the webinar series will be posted within a few days in the Resource Center. So this concludes today's webinar on how changes to the 2013 Physician Fee Schedule will impact pathologists. I'd like to thank you all for attending. Thank you.